Hey everybody, welcome to this year's HSCRC workshop. A little bit different than in prior years, but first of all, before we get started, I'm just a lowly consultant for many of you that are in the hospital field, working through this pandemic on the front lines and supporting your caregivers. I can't thank you personally enough. We really appreciate all of your efforts in supporting all of them. I think every year when we start the HSCRC workshop, I say that it's an unprecedented year of change. I guess this year's no different. But before we get started, I do want to thank all of our sponsors for the chapter. Even in a virtual year, they have stepped up and supported the chapter and allowed us to continue to bring relevant programming to you all that hopefully is making your work life that much, maybe a little bit easier, a little bit more enjoyable, and maybe you'll learn a thing or two along the way. We have a great agenda for today, but before we get into today's agenda, just a couple of housekeeping items. We recognize that it would be difficult for everybody to sit through a day-long HSCRC workshop, but we didn't want to shortchange you on content this year. And so we've actually split the HSCRC workshop into 2 days, very similar to today, 3 speakers, 20 minutes apiece, trying to give you bite-sized pieces. So that'll be in February. So if you enjoyed today's presentation, we'll have 3 additional fantastic presentations from folks at the HSCRC and from the Maryland Hospital Association that we'll be doing in February. And later today, if you're not aware, HFMA is holding a virtual happy hour. So I can give some more details around that, but we'd love if you attended, and we'd love if we were able to see your smiling faces and just do a little bit of networking. So looks like she is here. Hey, Katie. Want to introduce our first speaker, and bear with me because I have her bio on one screen and I hit it with the presentation, so I'm just going to make it up. Katie Wunderlich, as many of you know, is the executive director of the HSCRC. And has been for a number of years, leading us through these past few years of tremendous change and tremendous progress in the hospital field. Katie's been at the HSCRC for a number of years, even prior to the executive director, and also was chief of staff on the legislative slide for Governor Hogan, as well as worked on in the hospital field with the Maryland Hospital Association as well. So I'll stop droning on and let you all hear from Katie and virtually welcome her. Katie, I'll advance the slides for you, so just let me know whenever you're ready to go to the next one.
Thank you very much, James. And it's great to be here virtually with everyone. I do want to thank HFMA and the tireless volunteers that helped to put programming together, to reach out, to connect healthcare professionals throughout Maryland. So I want to thank James and Kalita and Cheryl and all the other folks who worked very hard to put this together. I would take some issue, James, though, with not everybody wanting to spend a whole day on HSCRC issues. I mean, I just can't believe that people would not want to do that. But really,
you want to, but there's circumstances that are limiting their abilities.
Yes, but really, thank you all for logging on today, for taking a little bit of time out of your schedules to here from the HSCRC. I get really excited when I'm able to talk to groups. I wish I was talking to you all in person, but hopefully maybe more folks can dial in because it is virtual. I'm looking forward to this engagement because I always like to be able to highlight the work that we are doing and also the work that you all are doing in healthcare finance in Maryland to continue to advance value-based healthcare reform that improves health outcomes, that improves quality of care, and reduces the total cost of care. We are continually looking for ways to do that, to harness the power of value-based arrangements and other financial incentives to align both the hospital field and the provider field to advance healthcare reform. James, you can go ahead on to the next slide. So what I'm going to do today, just a little bit of how I'll go through my presentation. I'm going to do a little bit of HSCRC background, who we are, how our work supports the state, and then I'll also dive into our model agreements with CMS, of course, the all-payer model that ran from 2014 to 2018, and the total cost of care model, which we are in today. And then finally, I do want to take just a minute to talk about COVID-19. It consumes everything that we are doing. It has drastically changed everyday life as well as healthcare delivery. And so I do want to take just a minute to talk through that. So the next slide goes as a little bit of a highlight of who we are. The HSCRC, for those of you who are new to the state or new to healthcare finance, the Maryland Health Services Cost Review Commission, of which I'm the executive director. We are an independent state agency. Our primary responsibility is to establish rates for hospital services for both inpatient and outpatient regulated hospital services. And we also are leading the state's efforts to transform the delivery system and achieve the goals that we have collectively set for ourselves under our Maryland health model. Our commission layout, just to give a brief flavor, we do have 7 commissioners that are appointed by the governor and approximately 50 staff that help to implement the policies that the commissioners approve. The next slide is an overview of our very unique healthcare payment system. Our approach is really buttressed by two elements on the left-hand side. One is our agreement with CMS, and which waives Maryland from IPPS and OPPS payments. That is a unique agreement that we have with the federal government. It was previously in federal statute. It is now in a contractual arrangement with the Centers for Medicare and Medicaid Innovation, CMMI. That arrangement sets financial goals, quality goals, and of course waives the state from the national Medicare payment system. On the other side that buttresses our model is our all-payer hospital rate setting system, which is embedded in Maryland state statute, and it does require hospitals to charge the same rate for all payers across the board, and for payers to pay that HSCRC approved rate. So it's unique to Maryland. There's a number of benefits that these two elements together produce for Maryland that you'll see on the right-hand side. First, it does enable cost containment for the public because of the financial targets that we have with CMS. However, because we have an all-payer system, it also accrues cost containment for the privately insured as well. It incentivizes better all-payer health outcomes through our quality pay-for-performance programs. It avoids cost shifting across payer and provides equitable rates to self-pay customers. And I think that's one of the elements that is most unique and very advantageous to patients and payers in Maryland. That whereas in other states, hospitals may shift costs rather to other payers in the system to make up for low public pay reimbursement. In Maryland, everyone pays the same amount, so that Medicare and Medicaid are required to pay a little higher to be true pay for true costs in the system, and that holds down the cost for the privately insured patients. We do share equitable funding of uncompensated care and other social goods and medical goods like graduate medical education, population health, infrastructure for our health information exchange, a number of other supports for the state, which you can see on the next slide. James, if you wouldn't mind, the next slide goes through some of the other ways that the rate setting system supports the overall healthcare delivery system. So we are focused on hospital and hospital care and delivery of care in hospitals. However, we understand that healthcare is broader than that. And so the rate setting system does help to fund and support other parts of our system, including CRISP, the state's designated health information exchange, which those of you who have been in the state know how wonderful of a resource CRISP is. Those that are new to the state will find out what kind of rich information you're able to get from CRISP. Some other state infrastructure support include the Maryland Patient Safety Center that advances safety and best practices across hospitals and post-acute settings. The Maryland Healthcare Commission, which is our sister agency that helps to plan, does healthcare planning in the state, nurse support programs, and Medicaid, the Medicaid deficit assessment, which supports both the Medicaid program and the state revenues generally. So that's a little bit about who we are and the, how we are set up in the state. The next couple of slides that I'll go through detail the contracts that we have with the federal government. This first one, the Maryland all-payer model, began in 2014. We'd previously had an all-payer rate setting system that dated back to the 70s. But in 2014, that all-payer the waiver for Medicare payments transitioned from statute into a contract with CMMI. And it really helped us focus on other parts, not just containing cost, but really moving from a volume-based system to a population-based system. It advanced per capita value-based payment framework for hospitals. It enabled providers to lead innovation efforts. It continued savings to Medicare and also helped to sustain rural healthcare through the global budget model. We had a few financial targets and quality targets that we had, you can see on the right-hand side of that slide, to put hospital revenue under a global budget system, to contain all payer hospital per capita revenue growth, and to produce Medicare hospital savings of $330 million over 5 years. We also had quality goals. One was to reduce our Medicare readmission rate down to the national average. Another was to reduce the number of preventable conditions in Maryland under the Maryland Hospital Acquired Condition Program. The next slide shows the results of that effort. We far exceeded both our cost and quality targets. You can see we accrued, our goal was $330 million worth of hospital Medicare payments, and we accrued $1.4 billion in hospital Medicare savings. We produced a total cost of care savings as well, and improved our quality positions. The next slide shows some of our transition from the all-payer model to the total cost of care model. So as I mentioned, we did cumulatively save $1.4 billion in hospital savings, However, our total cost of care savings, the Part A and Part B, hospital and non-hospital, the cumulative savings was only 869, meaning that those Part B expenses eroded the hospital savings. So there were dis savings on the Part B side that eroded the total savings on the hospital side. And this is partially a good thing. It's partially due to the incentives of moving low acuity cases from an inpatient setting to an outpatient setting. We also prioritized preventive care, preventive measures, and coordination with community-based and non-hospital providers. We did recognize that we had an opportunity to really dive in on that Part B side of the books to produce total savings for CMS and for the Medicare program. And so we really had our eyes on transitioning from a system that looked only at hospital cost and quality to a total cost of care, cost and quality on both the hospital and non-hospital side. And the next slide gets into our total cost of care model. This agreement we entered into with CMS in 2019. It runs for 10 years until 2028. It builds on the successes of the all-payer model and builds on the structure of the all-payer model. We do have financial goals and quality goals, again, under the model. Very important for us to not only look at our cost savings, and now we're looking at cost savings on not just hospital, but we're looking at Part A and Part B, hospital and non-hospital costs. Very important to try to bring those costs down, but equally as important is to look at the quality measures and making sure that we are enhancing health outcomes, focusing on reducing chronic conditions, population health improvement, et cetera. So this slide talks mainly about the financial targets, and for the total cost of care model, we do have a 5-year window to build up to annual Medicare total cost of care savings. So in the first part of the model, we had to produce cumulative hospital savings that we could accrue over the life of the model. In this model, we have to demonstrate that we have continued annual savings each year. We have savings targets that we have to meet in each year leading up to the 5th performance year, which is 2023. By 2023, we do have to demonstrate that we have an annual total cost of care savings of $300 million. So that is what we are building up to. We have levers in place to help us to meet those goals. But again, those financial goals alone will not be enough to make the case for why care and care delivery is different in Maryland. If you move on to the next slide, the next slide shows some of the other model components. As I mentioned, the total cost of care model does run basically on the all-payer model structure. So it builds off of the hospital population-based revenue GBR structure that was in place and under the all-payer model. It builds on that by adding additional total cost of care accountability for hospitals through a Medicare performance adjustment and other quality targets such as potentially avoidable utilization and reduced readmissions. But then it also builds on other elements. The number 2 is care transformation across the system. And those really are our care redesign programs, care transformation initiatives, which you will hear about later on in the program. And programs that we can put together on a voluntary basis to include and incorporate providers, nursing homes, and other non-regulated entities that HSCRC does not regulate, but that are very important parts of the healthcare delivery system and financing system. Another way we're trying to transform care across the system is through the Maryland Primary Care Program. This is a program that provides enhanced payment for primary care providers to provide additional services to their panel of patients, specifically for their Medicare patients, but hopefully to expand past Medicare shortly. It's to enhance chronic care and health management of high-risk individuals, Medicare individuals. And then the third component of the total cost of care model is the population health component. And this is a quality component that we are adding on the total cost of care that goes beyond just hospital-based quality to look at the health of the population overall. We're looking initially at diabetes, reduction of incidence and severity of diabetes, substance use disorders, specifically opioid addiction, and maternal child health. So those are three of the population health areas that I'll talk about shortly that we are focusing on in the model. The next slide shows the Maryland Primary Care Program. This is a program that is run through the Department of Health. It is a CMMI program. It provides tracks to primary care providers to manage the health of high and rising risk individuals in the community, and it provides enhanced payment to do that. And with that enhanced payment, primary care providers can offer additional supports to their patients, such as telemedicine, embed behavioral health and substance abuse counseling, care managers, and other patient supports. So the point of the program is to really connect patients with the care that they need to manage chronic diseases and improve their health. The next slide shows just the uptake of MDPCP. We have had enormous support among providers for this program. We're hoping to continue to build it and also to continue to add accountability for the program to improve it through accountability. The next slide is, as I mentioned, our population health priorities. As I mentioned earlier, these are three areas that we are adding as population health outcome measures. One is diabetes prevention and management. As I mentioned, the second is opioid screening, prevention, and treatment. And the third is maternal child health. And this is really to demonstrate that, as I mentioned, we're not just focusing on containing costs. We're not just focusing on reducing financial levers in the system. We are really focusing on transforming the way we deliver care and focusing on chronic diseases through these population health priorities. The next slide goes to some of the grant programs that HSCRC has to support the total cost of care goals. We provide additional financing to hospitals through their GBRs for these grant programs. The first is regional partnership catalyst grant programs, which my colleague Tequila will be talking about also later in the program. This is a really important program, as she will mention, that connects hospitals and their community organizations and community-based provider groups to tackle those population health areas. The second grant program that I wanted to highlight is the population health workforce support. And this funds community health workers, peer recovery specialists, and nurse techs for community-based jobs. And it specifically targets and recruits candidates for those positions from low income and low socioeconomic areas in the state zip codes. And so it connects workforce with community health jobs. We also have grant programs for Medicare Advantage and for COVID-19 long-term care. These are some of the grant programs that we have where they evolve and change each year as we support the goals of the total cost of care. We're trying to make sure we are focusing our resources to support those statewide goals, not just through the hospitals, but encouraging hospitals to work with their community, state, local organizations. So that's the overview of the model. I did want to spend just a minute to talk about the model in the context of COVID-19. Of course, this has changed. COVID-19 has changed the way people access care. It's certainly through hospitals and other providers on a very tumultuous ride over the last year. Trying to make sure they were able to have enough resources to care for people that came in with COVID, to also continue the care for non-COVID patients. There was a need for resources for PPE, for staffing. There were a number of resource issues that hospitals in Maryland and across the country were facing, especially in the beginning of the pandemic, when there was so much uncertainty, both of what exactly how COVID-19 would play out, and also uncertainty as to what volume or amount of patients would come in to their doors to be able to get the revenue needed to get those resources. And so we in Maryland took some proactive steps, and the system that we have set up in Maryland really helped to provide some key advantages to Maryland hospitals, some very essential stability for financial resources and revenue that was not available in other states. So first and foremost, the Maryland's global budget revenue system, which is based on population rather than volume, provided that additional financial stability, especially in the beginning when volumes really dropped out as people were avoiding hospitals, elective surgeries and procedures were being canceled. The GBR system allowed hospitals to continue to dial up their charges, adjust their charges in order to bring that revenue in that they desperately needed to transform their hospital, to provide the PPE, to staff up, et cetera. We were able to take these proactive responses because we have a state rate setting system. We were not dependent on federal action. We were not dependent on additional funds that Medicare was able to provide. Maryland hospitals certainly were able to also take advantage of that, but we were able to do some things early on to be proactive, to provide some additional resources and reassurance. These protections exist for hospital regulated revenues, but not for the unregulated revenues, as you know. Net operating revenue for regulated services in Maryland in fiscal 19, just to give you an idea, totaled 15 billion, whereas unregulated services totaled 1.8 billion. So the GBR, the point of that is that GBR was able to provide some protection for that 15 billion. It's higher than 15 billion now in fiscal year 21, but you get kind of the sense. The GBR really provided protection of that revenue so that hospitals, their teams, and their healthcare providers could focus on taking care of COVID-19 patients, preparing their hospitals, their workers to care for a very uncertain virus that people did not know how it was going to react. So that financial stability really allowed hospitals to focus solely on caring for patients. Maryland hospitals were able to retain that revenue, charge that revenue, and then use that for the operation of their hospitals. Outside of Maryland, of course, the fee-for-service hospitals lose that revenue. And so we think that's a real advantage to Maryland and our global budget system. So that's really all I had today. The last slide is really just a review of our unique approach to healthcare. It ensures equitable and equitability of hospital charges, enables the state to link health outcomes to payment through pay-for-performance programs, supports state infrastructure, promotes population health, and provide stability in very uncertain times. So I'll stop here and take any questions that you might have or any comments that you have. Still, again, want to thank HFMA for having us here today, and also want to echo James's thanks to all of the healthcare workers and the finance folks that help to make sure that the frontline workers are able to do their job, because this pandemic has been a huge stressor on everyone, and want to thank everybody who's in the hospital industry for their work and their support through this pandemic.
Well said. Thanks, Katie. So being this is the first webinar that I'm running for HFMA, I think what I would like folks to do while I'm stalling for time here is type your questions in the chat box, and I can read them out. I'll start with one question, Katie, which I think will be a little bit of an easy one for you. What are the top 2 or 3 things that are top of mind for you from a policy perspective over the next coming months?
So over the next coming months, I would say the next year or so, we are really looking to focus on our quality care transformation initiatives, advancing the care transformation initiatives, advancing quality and population health in the state. We have a track record of being able to deliver huge financial savings to the federal government and savings to other payers in the system as well, namely private insurers. We have a lever to do that. We've been able to produce huge savings. What our challenge is, our challenges for the total cost of care model, and as we look towards the future, our challenge is to demonstrate the value of our waiver, the value of our system, not only for containing costs, but really for improving health outcomes, for improving patient experience, reducing chronic conditions. If we can, as a state and as a system, focus on perhaps beginning with those chronic conditions, diabetes, substance use, and maternal child health, if we can focus on those as a system, I think we can really tell the story of the value of our model, not only the value that it gives for hospital financial folks that can that have a little bit more stability in their budget, but really, how is this improving health for Marylanders? How is access improving, telemedicine improving, quality improving? So that's where I'm going to be focusing on, where we really want to make sure we have the right incentives in place to demonstrate that the value on the quality side.
Great, and I have one more question here that I'll paraphrase for the attendee. So it says, in effect, with all the successes that we've had in our model here, what do you think are lessons that could be learned and applied in other states from the Maryland model?
So I think the population-based budgeting approach is one that I think can be translated to other states. They're already doing that in other states for Medicare, and but I think that is one of the lessons that the Maryland model has demonstrated over the last, since 2014, since we've transitioned to global budgets. We have seen a stabilizing factor for hospital margins. We've been able to ensure continued hospital margins, but we've also avoided the volume or the big drops in revenue that other states have seen and other provider groups have seen. And we've also even been approached by, this is a hospital-based model, the GBR is, but we have been approached by other provider groups that are interested in population-based arrangements. And I think the pandemic highlights some the vulnerability that providers on a the fee-for-service system face. That when volumes drop or when there is volatility, they have no protections for their resources through those changing volume times. So that's one of the lessons I think we could take forward.
Awesome. We wanted to do this as quick hits, and that 20 minutes went really quick. There's some other questions that are out here, but unfortunately, we'll have to table those for another time. But Katie, thank you. Thank you for presenting, and thank you for making your staff available to present to the hospital field. We're going to take a 2-minute break as we get the next presentation up from Tequila, and so we'll be ready to rock and roll by 9:40 here. So grab some more coffee, grab a muffin at the buffet, whatever it is you so choose, and we'll be back with you in 4 minutes. All right, Tequila, you there? Hey.
Hi.
All right, I think we are ready to rock and roll again. Let me pull up your presentation. Can you see it?
I can.
Perfect. All right, everybody. Welcome back. Just as I get a little bit better at this, the second time around, if you have questions, my suggestion would be to type them in the question and answer box in your Zoom browser. Feel free to do it throughout the presentation, and that way I can line up the questions for Tequila at the end of the presentation. We can go through them rapid fire. I'm excited to introduce Tequila Terry. I actually haven't had the pleasure, I think, of inviting Tequila to the HSCRC workshop virtual stage. So welcome, Tequila.
Thank you.
Tequila is the director of the Center for Payment Reform and Provider Alignment. She leads the team responsible for collaborating with the hospital systems on transformation and payment reform initiatives, as well as legislative affairs, communications, and grant strategies. So let's give a warm virtual welcome for Tequila, and take it away, Tequila.
Thanks so much, James. Well, good morning, everyone. I'm delighted to be here today, albeit virtually. I look forward to, sometime in the future when we can all get back together in person. But for today's session, I want to sort of build off of some of the topics that Katie started on this morning by focusing on our Regional Partnership Catalyst Grant Program. And I want to put it in the context that Katie started to describe, that the total cost of care model really sort of provides this opportunity for the state to focus on population health initiatives and really through our statewide integrated health improvement strategy. So I'll talk more about that. So James, if you can move the slides forward. So Katie already explained who we are, so I'll ask you to go ahead and move forward one more time. So in Katie's prior slide, she showed this diagram. And so I'm going to be focusing sort of in that lower box on the left, the dark blue box, where part of the total cost of care model focus is to build out really initiatives focused on population health improvement. And we have a specific agreement in place with CMS to focus on this. And I think that's, again, one of the elements of our unique model that makes it very special and really creates sort of this differentiator for Maryland as compared to other states across the country. Next slide. So by way of background, I want to talk about first the statewide integrated health improvement strategy, or SIHIS, as we refer to it. And really what this is an additional agreement, a memorandum of understanding that was established with CMS at the end of 2019. And what this MOU did was is set forth an agreement to have Maryland create what we're calling this statewide integrated health improvement strategy. This initiative is really designed to engage both state agencies, private sector resources, to work together on improving health, addressing disparities, reducing costs, by focusing on the three domains of healthcare that you see on the screen. So by focusing on enhanced hospital quality goals, in domain 2, focusing on really facilitating and fostering care transformation across the system as measured by value-based payment arrangements that we have in the state. And then finally, and where I'm going to focus for today's presentation, is on this third domain, really the idea of improving statewide or total population health, with the goal of focusing on key health priorities that we as a state have identified. And it's from this area that the Regional Partnership Grant Program really has stemmed from as a mechanism to support that total population health domain. Next slide. So in this domain, in the area of total population health, really the state's objective was to establish health priority areas or focus areas that we collectively as a state would work on to improve under the total cost of care model. And so, as Katie alluded to in the prior slides, there's 3 areas of focus. The first priority area is diabetes, and this was identified as a statewide priority under Maryland State Secretary of Health, Secretary Neal. And the Maryland Department of Health actually issued in 2019 a statewide diabetes action plan, sort of setting forth diabetes prevention and management as a priority. The second priority area is on opioids. As you all know, this is a crisis that has been going on for a number of years, not just in Maryland, but across the country. But in particular, it was identified as a statewide priority by both the Governor Hogan and Lieutenant Governor through the Maryland Heroin and Opioid Emergency Task Force in 2015. And so this has been a long-standing priority in the state. And so that was the second priority area that we wanted to focus on under this umbrella of total population health. And then the third priority area is the maternal and child health priority. And this was identified as a result of legislative activity, specifically House Bill 520, Senate Bill 406, which really focused on creating a task force to look at what Maryland could do to better address the challenges that we face across the state in maternal and child health. So these 3 areas, through a variety of state action and initiatives, have been identified as key priorities that we wanted to focus on as part of this statewide health improvement strategy. Next slide. So as a result of that, the HSCRC in 2020 announced a program to issue funding to hospitals to work with community partners on health initiatives that were designed to focus on those SIHIS population health priority areas. The Regional Partnership Grant Program just launched at the beginning of this year, so not even a full month being implemented yet. But really, the purpose of this program was to support the goals of the total cost of care model, and specifically that focus on population health that has been set forth under our arrangement with CMS. And then to make sure that we are really demonstrating measurable impact of funded activities, particularly allowing hospitals and community partners to work together. So it's a 5-year program that will run through the end of December 31st, 2025. And really, again, is intended to make sure that there is funding available through the rate setting system, through hospitals, to be able to focus on these key health priority areas. Next slide. So the funding is sort of allocated in a way that really supports those 3 priority areas of population health. So we've allocated them, as you see here on the screen. The first funding stream is for diabetes prevention and management programs. And so the idea is that we wanted to be able to fund activities that hospitals proposed on ways that they could support the implementation of the CDC recognized lifestyle change programs for diabetes prevention and other evidence-based diabetes management programs. So the idea here is the diabetes prevention program, DPP, as well as other evidence-based management programs really intended to address the challenges that we see in the state with diabetes. The second funding stream is intended to support, again, sort of that opioid area. And it's to fund activities related to behavioral health crisis services. And really, we started with the Crisis Now behavioral health model for funding in this area. So hospitals, again, submitted proposals of activities they could do to actually strengthen the infrastructure for behavioral health crisis services. And then finally, In funding stream 3, maternal and child health was just identified in December as another priority area. And so we would be using the funding to support other interventions to improve maternal and child health. So I'll talk about each one of these a little bit more in the next slide. Next slide. So for that first area, that first funding stream, the Diabetes Prevention and Management Program, as I said, the goal here is to get hospitals and community partners working together on evidence-based programs that we know through data are actually successful at preventing and managing diabetes. So the DPP program, DSMT, medical nutrition therapy, those programs are incorporated in the activities that the hospitals and their community partners will be working on over the coming years, really with the goal of expanding the number of diabetes suppliers across the state, so diabetes prevention program suppliers, really getting more beneficiaries into the program and not just enrolled, but actually completing the lifestyle change program, which again, evidence shows works to curb the effects and the experiences people are having with this chronic condition. And then finally, the partnerships will be asked to or tasked with achieving weight loss goals and reducing diabetes-related hospital admissions. So both tying back to our model-specific hospital goals, but then also working towards those broader population goals. And so our rationale here was that, again, we wanted to promote an evidence-based program that would support that diabetes action plan that had been developed. And then also aligning Medicare with other payers who had already been taking steps really to foster the National Diabetes Prevention Program by funding it that way. So next slide. The second funding stream, again, is our behavioral health crisis services funding stream. And so here, the idea is, again, we're issuing funding to hospitals really to support programs that would align with the Crisis Now model that was developed by the National Action Alliance for Suicide Prevention. And the idea here specifically was that we wanted to focus on those elements that Crisis Now really emphasizes as components that would support a broader, stronger infrastructure for these types of services in Maryland. So the crisis call center and air traffic control services, these are the kinds of programs that use technology and real-time coordination across the system and really sort of leverage data to make sure that we are tracking patients and understanding where the resources are so that patients can be better placed in care settings appropriate for their needs. The community-based mobile crisis teams, which offer outreach and support services to locations where people are actually experiencing crisis within the community. And then these short-term subacute residential crisis stabilization programs, which offer some short-term support for individuals who need observation and really is a better placement option than the emergency department. And so the regional partnerships really will be tasked here with expanding the infrastructure and also making sure that it fits within the context of existing resources that communities may have. And ultimately, they'll be measured on reducing emergency department boarding times and repeat utilization. And again, here, the rationale that we used for this was that we wanted to promote the interventions that, one, created infrastructure across the state that would then ultimately lead to reducing unnecessary ED and hospital utilization, which is a core part of the model goals. And then if you go to the next slide, the final funding stream is our maternal and child health funding stream. And this one, again, was just added in December. So we're in the process of developing a plan for how we would support maternal and child health as a population health goal under the SIHIS initiative. But at a high level, the idea here is that there's two components that we would be focusing on in recognition that, health events as early as in utero and infancy, greatly affect individuals' health trajectories across the entire life course. And so recognizing that as a key lever and opportunity to address long-term population health, first supporting, severe maternal morbidity. We know that many of these events are preventable, and unfortunately, the state has a long-standing history of racial and ethnic disparities here. And then secondly, working on pediatric asthma-related ED visits. It's unfortunate, but we are seeing that through data that there are more ED visits than some other major chronic conditions that we're very familiar with, like hypertension. And so it's something that we as a state have been grappling with and wanted to focus on as part of this initiative. And again, this is another area that's been really marked by a number of disparities. Next slide. So the one thing I do want to underscore as part of this program is that, collaboration was such an important part of our thinking when we sort of framed this initiative, because we recognize that, there is this tremendous opportunity for hospitals and communities to work together in collaboration to address the conditions that I just identified that we collectively as a state have identified as priorities. And so, there's various requirements in the grant program to make sure that there is meaningful collaboration with communities. And the partnership the partnerships really are very diverse. While we sort of gave some examples of partnerships that we wanted to see and community resources that we wanted to see engaged, the hospitals actually went above and beyond. And so for the activities that were funded, you'll see in the next couple of slides that there's just a tremendous number of community resources brought together across all of these different types of entities. Next slide. So just very briefly, these are the organizations that have been funded, and you can see that it is a mix of both hospitals and community partners across the state. And so very deliberately in our funding strategy, we wanted to try to get to as many areas of the states with these regional partnerships, focusing on both urban and rural environments across Maryland. And then again, the requirement was to make sure that there was community partners. And so working together, the hospitals and communities to focus on diabetes prevention and management. The next slide, the same thing with the behavioral health proposals. And so the idea here is that we again wanted to make sure that there was strong representation of hospitals and communities working together across the state, really with the idea of improving, population health as really this idea of a collective impact initiative where people were working together under a common agenda with mutually reinforcing goals, really in an effort to improve population health. Next slide. So just in closing, what I'd just like to, just recap is that, this Regional Partnership Catalyst Program is really what we believe a significant opportunity to support that SIHIS population health area of the total cost of care model. The partnerships have been awarded and their funding or their activities, interventions are being launched now. And so for anyone who's interested in seeing more about the actual activities and initiatives underway, we've got summaries posted on our website for each one of the partnerships so that you can get more information. We also have points of contact so that if you're interested in getting involved or getting engaged, there are points of contact for each of the regional partnerships that you can reach out to. So with that, I'll stop and sort of ask James if there are any other questions or anything else we want to talk about. I'd you know, I could spend all day talking about this, but I know that we're trying to be brief. So James, let me know if there's any questions. I'd be happy to answer. And I think you're on mute, James.
That was bound to happen. So again, folks, if you have a question, shoot it over in the Q&A box. There is one question here, Tequila. It states basically the commissioners seem to have a lot of interest in what the ROI is related to these efforts. Can you share any thinking that you and the rest of the HSCRC staff have around measuring that ROI?
Yeah, and that's a great question. There was quite a bit of interest from our commissioners on, you know, what I would sort of perhaps rephrase as not necessarily ROI, but really measuring impact. And so this program is set up with what we call scale targets. And the scale targets really is what we thought long and hard about in terms of implementing, because we wanted to be able to demonstrate the impact of these grants, but also recognize that when you're focusing on infrastructure investment, you may not see you know, sort of a technical ROI or the traditional financial ROI right away. And so the scale targets were identified as an alternative way to measure impact. And so each of the grant recipients has agreed to a set of scale targets that range from, you know, sort of measuring year by year activities on what their interventions are expected to do. So, you know, in the earlier years, it may be sort of focusing on the steps to, you know, get up and running. And then in the latter years, being accountable for specific activities related to outcomes, measurement in terms of either, you know, body weight loss, for example, on the diabetes side, or looking at ED utilization or ED boarding times, wait times for behavioral health. And so very specifically, we wanted to focus on measuring what that impact could be, but thought that, you know, is more appropriate, since we're talking about infrastructure investments, really to focus on those things that demonstrate progress is being made to improve access to care, to implement these evidence-based programs in the early years, and then progressively build up to those measures that I described.
Awesome. Well, again, unfortunately, we are out of time. These are quick hit presentations. Thank you from the chapter, Tequila. Thank you for sharing, and we'll go on to the next speaker in about 5 minutes. So rejoin us at, let's just say 10:06, and we'll have Will Daniel wrap up today's session with a discussion around CTIs. Talk to you in a few minutes, everyone. Thank you. All right, everybody. Why don't we reconvene here? Will, you there?
Hi, James. How are you?
Good, good. Can you see everything, or Kalita, can we flip back to broadcasting?
You're good.
Cool. All right. So our final speaker of the day, Will Daniel. Welcome him back to the HSCRC workshop stage. Will is the deputy director with the HSCRC, responsible for payment reform. Prior to the HSCRC, Will actually was the model lead for the Maryland model back at CMMI. So we're going to ask Will to talk about his favorite subject today, the policies around the care transformation initiative. So again, if you guys have questions throughout the presentation, add them to the Q&A box, and I'll try to get them asked by the end of the presentation. So without further ado, Will, take it away.
Great. Thanks, James. I don't know. I can't see the slides. Do we have those up?
Oh, maybe I'm not. There you go. You got it now?
Yep. Thank you. I would be totally mute without PowerPoint, so I appreciate that. I'm going to talk about three things today. The first is why is HSCRC focused on these things called care transformation initiatives? The second is what the heck are they? And the third is, I think, interesting to the financial people. How do we evaluate them and reward them and pay for them? So if you could go to the next slide, please. Actually, another one. Yep, thank you. So the purpose of these programs, I think, is to do these three things. The first is ensure that hospitals get paid for work they actually do. Right now, I think there are a lot of really great incentives under the global budget model, but those incentives are incomplete to cover the total cost of care, and we think CTI is pushing into that new domain. And then the second is to evaluate the amount of work that individual hospitals are doing. We've had a lot of financial success under the all-payer model and under the total cost of care model on a statewide basis, but we really don't know who's responsible for driving that savings. You know, we report the savings rate at 300 million, something like that, but who is responsible for that? Who is the biggest driver of it? And are there any hospitals that sort of aren't pulling their weight? And then the third is to create an inventory of care transformation. Somebody previously mentioned earlier or asked a question, you know, what lessons can we take from Maryland and apply to other states? And I think there are some policy design lessons, but I also think the state is doing something very unique. There's been greater utilization reductions and reductions in potentially avoidable utilization than I think any other alternative payment model across the nation. But we don't right now have a good story to tell. I think there is a good story there. We're just not able to tell it about what is driving those utilization reductions. How have hospitals been successful under this model? And so the CTI process is an attempt to start creating an inventory so that we can tell that story a little bit better. Next slide, please. So to the first objective, right now, hospitals have an incentive to reduce their unnecessary utilization under a global budget, but they're primarily rewarded for reducing their own hospitalizations. They're not really rewarded for reducing unnecessary SNF cost, unnecessary elective surgeries, and they're also not rewarded if they go out into the community and do this great population health intervention. If it happens to avoid a hospitalization for their neighbors down the road. That might be very neighborly of them, but it's not in their financial interest. And so you can think of that as a pretty significant barrier, I think, to hospitals being very aggressive about their transformation strategies, particularly in urban areas where there's a lot of overlap in hospital market areas. So that what the CTI are intended to do is fix that by attributing a population to a hospital and to a hospital intervention, and then making sure that hospital gets paid for the success on that population, regardless of whether it's a utilization that's reduced at their hospital or their neighbors down the street, or whether the savings come from the hospitalization side or from the physician or the SNF side. Next slide, please. So the second rationale, in a little bit more detail, is to try and take that run rate that we talk about. So Katie talked earlier, our commitment to CMS is to save $300 million per year by 2023 for CMS. And we're well on our way or beyond that target already. But the primary way that we've achieved those savings historically has been using the update factor. And the update factor is spread across all hospitals. And so we are succeeding using a purely financial lever. What we don't really know is which hospitals have done the most in order to support that financial savings through their care transformation efforts. And it might be that all hospitals have been transforming and engaged in sort of effective population health management in equal measure. Or it could be that some hospitals are doing a little bit more and other hospitals are doing a little bit less. And we as policymakers, I think, need to understand the level of effort and the level of transformation at individual hospitals, because it has implications for some of our other policymaking. You know, we've talked about retained revenue. As the hospital reduces utilization, they keep the revenue, and what do they do with it? Well, if they're investing it in population health management, then that's good. But if they're one of the hospitals that isn't doing transformation or isn't doing as much population health management, then that has some other implications for policymaking. And so I think these CTIs are intended to add a little bit of vision into the efforts going on at hospitals. Next slide, please. And then the last purpose that we're trying to accomplish with these CTI is to get an inventory of those interventions. You know, when I worked at CMMI, I get a lot of questions about, you know, what are Maryland hospitals actually doing to reduce potentially avoidable utilization? And we had some sort of illustrative examples, but there was no systematic understanding of their transformation efforts. And I think that's sort of a weakness of our ability to tell good stories about the model. We have very good high-level outcomes, but if you talk to docs, their eyes sort of go cross when you talk about a financial run rate or, you know, per beneficiary per month payments, et cetera, et cetera. They want to know, how has care improved for the beneficiaries or the patients that they see? And I think we need to get a little bit better about creating inventories and being able to tell stories there. And that's the third objective of these care transformation initiatives. Next slide, please. One more. So I think sometimes when we talk about payment reform, we just end up talking about a lot of acronyms, right? So I used to, you know, say, when anybody asked me, what do I do? When I worked at CMS, I'd say, well, I work at CMS, I work in CMMI, I work on these ACO models, right? And it's just like 3 acronyms, one after another. And to some extent, you know, payment reform seems to be taking concepts that we've been using since the 80s and attaching new acronyms to them. So I wanted to define very precisely what a care transformation initiative is, so that we can sort of understand what we're talking about here. The definition, though, I think is very broad, and I think that's good in some ways, but bad in other ways. So the definition, you know, that I would say is care transformation initiative is any initiative undertaken by a hospital to reduce the total cost of care of a defined population. That's not like a good definition, right? If it's just any initiative, that's very broad. The reason why it's so broad is that we want to provide hospitals with sort of maximal flexibility. If you've been around the state for a little while, you'll know there's a sort of long history of HSCRC coming up with clever acronyms and clever little programs to try and manage the total cost of care. And I think that the CTI program is an evolution in that sort of trajectory where we say, you know, you guys are the experts. Hospitals know how to do this. We really don't. So we want to ask hospitals, what are you doing to transform care? And you can define whatever intervention you want, and we will come up with, you know, a financial methodology in order to incentivize that and make sure that the hospital gets paid for the work of whatever that intervention is. And so a CTI, I think, is intentionally very flexible. It has 3 components, so every CTI must be able to have these 3 components. But other than that, the hospital has, you know, as much flexibility as we can provide in creating these CTIs. So the first component is a clinical intervention. The hospital actually has to be doing something. Don't really care what the clinical intervention is beyond our interest in creating that inventory and telling a good story about the way that the delivery system is improving in Maryland. But there does have to be a clinical intervention at the core of the CTI. The second requirement is there has to be a population that the hospital is targeting with that intervention. And you have to be able to define it. You have to be able to identify the claims data for that beneficiary so that we can attach sort of a financial construct to them. This is a little tricky. You know, you can think of a lot of very good initiatives. You know, I know one hospital has been doing this sort of safe streets program or trying to close food deserts, et cetera. Those, I think, are really good population health interventions, but they're very hard to identify a population, right? You can't identify the population that walks into your street, right, very easily. And so that wouldn't be an appropriate CTI, right? We'd have to come up with some other policy to incentivize that. You have to be able to say, you know, I'm focusing on people with COPD or congestive heart failure or diabetes, et cetera. And then the third component is what HSCRC will do. So once that hospital identifies the clinical intervention in the population, HSCRC will say, okay, you know, we have your population and actuarially they should cost $10,000 per year. And now your job is to keep the total cost of care below $10,000. And together those 3 components create a CTI. Next slide, please. So I've given a couple of examples of the clinical interventions. I think we'll distribute the slides and there's a lot of words here, so we can move on to the next one. So as we talked about previously, the population definition is really, you know, a claims-based sort of targeting criteria, right? The hospital has a lot of flexibility here. They can use basically any criteria that shows up in the claims data, and that's a lot of information. You know whether somebody has ever received a hospitalization, ever seen a doctor for a particular condition, et cetera. You know where they live, which doctors they see, so on and so forth. But you do have to be able to see this in the claims data. This is, I think, sometimes limiting, despite the amount of information that's available. You don't, for example, know in the claims data what an individual's A1C is or other clinical information that's on the medical record. It really has to be a billable condition. So I think this provides a lot of flexibility for hospitals, but at the same time is slightly limiting because it doesn't get fully into the claims data, into the medical record and the clinical data. Hopefully someday in the future, we'll be able to get a little bit better. You know, claims data was created for payment purposes and not for clinical population health management purposes. And so, you know, at someday we should move beyond it. You know, if your hospital wants to be the brave first hospital to let us poke around in the medical records and use that to identify population health management, please let me know. But so far, no one has taken us up on that option. Next slide, please. So part of the problem that we have once we just identify the population that you're targeting is we don't actually know who gets the intervention. So if you're targeting people who have diabetes and you're trying to enroll them in a diabetes prevention program, we can identify who has diabetes, who lives within your service area, et cetera. But we can't always identify who actually goes to the diabetes prevention boot camp or whatever intervention actually exists. And so we're measuring this on an intent to treat basis. You tell us who the population you intend to impact is, and we will measure the impact that you have on that overall population. Ideally, the population that you actually intervene on and the population that we're measuring on are very close, but there are sometimes a little bit of misses there, and that's a further limitation of the program. But on the other hand, it does create an incentive for a hospital to ramp up their intervention as broadly as they can across the target population. And that sort of serves HSCRC's purpose, right, where we want to scale care transformation as broadly as we can across the targeted population. Next slide, please. So the third component of the CTI is a target price. This target price is actually very simple in concept. This just says, you've told me what your population is. I'm going to tell you how much they should cost, based on some actuarial analysis. And you win if the costs are less than the target price, and you lose if the costs are greater than the target price. This is, your normal benchmarking or target price methodology for any other alternative payment model, if you're familiar with ACOs or bundled payments, et cetera. Next slide, please. So, an example that I took from one hospital, just to illustrate, what the heck a CTI actually is. This is a hospital that was targeting patients with a number of chronic conditions, so COPD, AMI, depression, et cetera, and who are, relatively frequent users of the hospital, somebody who's been to the hospital in the past 12 months, probably not your frequent flyers, but somebody who's definitely, a rising risk patient with one of those conditions. The clinical intervention that the hospital provides is a, multidisciplinary team, trying to provide some sort of this patient-centered care, PCMH-like activities that wraps around the medical services that they are provided, and tries to get the beneficiary linked up with, medication reconciliation, transportation, et cetera, et cetera. We would look at this, and based on our actuarial analysis, provide a target price. Generally, after a beneficiary, with one of these conditions goes to the hospital, their total cost of care over the next 90 days is $26,000. That's an example, but I think it'll work for us. So we just say to the hospital, for all your patients that meet these criteria, try to keep the total cost of care below $26,000 using this clinical intervention. And if you do, you'll be rewarded. Next slide, please. So I'm going to dive a little bit more into the financial methodology. As always, things are simple on the surface and then get more complex the farther you dive into them. So the target price basically is looking at how much did that similar population cost in the prior year. We have to do some risk adjustment. We have to do some inflation adjustments, et cetera, et cetera. But in general, this is just saying, if you're targeting the population with COPD, last year they cost $10,000. This year, try to get it a little bit under $10,000, but that's essentially your target price. So not hugely complicated. The complicated part about the CTI financial methodology, I think, comes in this what we call the CTI offset. So if we were to pay all hospitals for reducing the total cost of care, we would actually eliminate any savings to our payers, right? To CMS, that would hurt our contract performance, et cetera. In other words, let's say that the state created $10 million in total cost of care savings, and then we paid $10 million to our Maryland hospitals. That actually zeroes out any savings to the payers. So what we do with the offset is we make sure that all CTI payments are budget neutral across the state. That means if one hospital provides or saves $10 million in total cost of care, the other hospitals in the state have to pay a little bit in order to ensure that that hospital can get that $10 million. That has a couple of purposes. The primary one is preserving the savings to CMS and Medicare. But the second is that it actually creates an incentive for hospitals to participate. So if you know that hospital down the street has a really good intervention, they do really good primary care management, something like that, you know, you're probably going to end up paying for that hospital's program and the savings that they create. And that if you want to, you know, sort of avoid a financial penalty, you would need to do an intervention and produce savings that's equivalent or greater than their program. And so if we have one hospital in the state that has really good primary care management, for example, it sort of creates an incentive for all other hospitals in the state to also engage in primary care management and to do a little bit of competition to see who can do it the best. And that there's some redistribution, right? Hospitals that are bad at primary care transformation will end up paying the hospitals that are good at primary care transformation. And theoretically, that competition should result in greater both CTI participation, but also successful programs, or at least that's the hope. Next slide, please. So the target price methodology, as I mentioned, very simple. Just take the baseline period costs, multiply by inflation, and do some risk adjustment, and you have a target price. And then you can determine the amount of savings just by comparing the actual total cost of care to the target price. So relatively simple in concept. And I realize that we have 1 more minute left. So I'm going to move on to the next slide, if you don't mind. And I think here, you know, sort of similarly, there's a very simple concept. All the payments are made net neutral. If you are one of the hospitals that produces savings, you will get paid. If you didn't produce savings, you will pay the hospitals that did succeed. And so I try to illustrate this down here with the smiley faces. You know, if you save money, you're going to be a smiling face, and if you don't, you're not going to be smiling. So that's my 1 minute description of how the offset works. Next slide, please. I'm happy to answer any questions.
All right. We do have one question here, Will. The question is, are CTIs a requirement of the total cost of care agreement with CMMI? And if not, and Maryland hospitals have been successful in a variety of different ways, do you believe an extra measurement policy is necessary for hospitals to undertake to prove the model's success?
Yes, so it's a great question. It is, the CTIs are not a requirement of the total cost of care agreement, but I do believe that they are absolutely necessary to prove our success. So the reason why is, if we were to succeed purely on financial levers, right, that we just adjust the update factor and set payment rates for hospitals, and we didn't actually change the way that care was provided in the state in a better and more sustainable way for the future. So if we're producing savings purely on the basis of financial levers, CMS is going to look at us and they're going to say, well, we know how to set payment rates for hospitals, and we could probably set payment rates that produce more savings for CMS faster. And so, you know, there's not a strong rationale for us to say, you know, we're better at setting hospital payment rates, particularly when the Medicare payments in Maryland are substantially higher than they are in other states. I think the purpose of the model is to invest in a delivery system that is sort of better than one you would get under a fee-for-service volume-based reimbursement system. I don't think you know, if you ask any economist in the state, in the country, and you'd be like, does the fee-for-service volume result in better quality care? They'd be like, no, that's not what it's incentivizing. It results in more care. And so I think that CMMI partially views its mission and objective as investing in transformed delivery system in addition to a cheaper one. And you can see that in their statutory mandate and in the other models that they advocate and have created.
Great. We are again out of time, so I do want to thank Will, thank the HSCRC staff Couple reminders before you hop off. We do have a virtual cooking event tonight at 5 o'clock. Network with your peers and learn a couple things that you might be able to implement for dinner tonight. And then our second part of the HSCRC workshop is coming up in mid to late February. I don't remember the exact date off the top of my head, but there'll be more communications about signing up for that event. In that event, we'll be talking about not only what the Maryland Hospital Association views as the state of the waiver, but also the full rate application methodology, as well as what the HSCRC is thinking related to the CARES Act. So a lot of very relevant topics, timely topics, and we'd love to see you again today. So again, thank you to all of you for attending. Shoot us any comments if you have comments or questions about today's event that we can do to make better for round two. But thank you to all the presenters and the sponsors for their participation today. Have a great weekend, everybody.